This is Sg2 Perspectives, a conversation with Sg2 experts and industry thought leaders about the biggest trends in healthcare and what we expect that's going to mean for the future of healthcare delivery.
When you consider all of the procedures across every different service line that have the ability to go to ambulatory surgery centers, orthopedics and spine are pretty high up on the reimbursement in hospital-based settings still. And they're also more complicated. They have larger equipment. Sometimes they have a lot of trays. We have robotics to consider. And then some health systems across the country still haven't migrated to their ambulatory surgery centers, ophthalmology, GI.
Hello and welcome to Sg2 Perspectives. I'm your host, Tori Richie. Today, I am joined by our Sg2 spine experts, Donnelle, Jageman, and Kate Zentner. Donnelle, Kate, thank you for joining.
Good morning.
Thanks for having us.
Spine has been a really popular topic over the last couple of years. We've seen a lot of innovation in this space, which has led to de novo site of care developments. We've seen some site of care shifts happening. What are you all seeing at a programmatic level as it relates to building out spine programs across the country?
Programmatically, we're finding that while we're still very much focused on the same core features that we've always talked about that make spine programs successful, so that would be things like having a well-oiled triage mechanism, interdisciplinary workforce. These are the things that a lot of the programs that we're working with have explored at this point. But what's been interesting in the last 6 months to a year is that a number of the organizations that we've often featured as case studies to exemplify those core features are now starting to revisit their own processes and structure to reassess what that next iteration of their spine program is going to look like. There are a couple of reasons that some of these programs are pointing to that we're hearing for this. One of them is scalability. Maybe they've outgrown the processes that they have now, or maybe they've been leveraging legacy infrastructure, whether it's a facility or facilities, or maybe a call center that wasn't necessarily built for the spine program, and they feel that they need to go back. They're ready for dedicated infrastructure. Or they might be thinking bigger, trying to aim for some consistency across a broader system or region. So scalability is number one. The second that we're hearing is related to workforce. We see ongoing experimentation, particularly as it pertains to who can be the first point of contact or that first visit for a patient and where that can happen. Advanced practitioners, physical therapists, physiatry are some of the potentials that programs have done some trial and error with how to use those folks over the last 10 years or so. And then finally, sometimes with workforce, what drives this need for reassessment is when important players in a market or a program change, whether they're retiring or they're moving around. Donnelle, we've heard that as kind of the impetus for assessing the next wave of spine program quite a bit recently.
Yeah, those physician champions tend to be really important in these programs, especially when you have more of a programmatic structure versus a facility-based spine program. You need somebody to connect all the dots, keep everyone engaged. And we've heard some successful programs working on that model recently as well, even with a very diverse physician workforce.
Does that lend itself to driving operational or clinical efficiencies? I'm just thinking the growth that exists in the spine space is huge, particularly as we're facing the booming aging population. In terms of programs kind of already sitting at capacity, are they thinking about how to leverage that programmatic approach to drive efficiencies to then increase the number of lives they're able to reach?
Yes, there are some lagging indicators you can start to look at to see, or performance metrics to start to assess whether or not it's an operational issue that we're having issues with capacity, or maybe if we're needing more providers and need to grow. We don't see the wait time issues with spine programs quite to the same extent in neurology, where we can see months plus wait times to get into some of those specialists. That can still be an issue. Some of the others we look at are conversion rates, a number of metrics to paint a picture of how we're doing. And then we can start to figure out it is refining that triage process, figuring out who is the first stop, just by making some simple changes and figuring out the process for that initial phase with the patient. We've seen tremendous improvements operationally, reducing wait times, even surgical conversion rates. That first step where you can get providers and physicians more engaged because they see that we're making progress early.
The triage process can be very cultural in spine programs. When you have one program that has an advanced practice provider who's doing triage, maybe that red flag exam might work great for your program. That might not work for another program where you need to have a physical therapist or a nurse navigator do some of that work instead. Our one recommendation, Kate, is that it is a clinical triage.
It can have tremendous impacts operationally. Some of those metrics a lot of spine programs are measuring and really thinking about whether it's wait time, surgical conversion rates, those sorts of processes can have a big impact on that. The other piece that we are seeing programs work on operationally is just how to maximize the use of the advanced practitioners that we have looped into these programs. Pretty much all of the spine programs we talk to do use them at this point. It's figuring out, are they going to be site specific, maybe just in the OR, just in the outpatient clinic? Are they going to be that initial point of contact for a patient? And how do we keep them engaged? That's another issue that programs have been thinking about. How do we use our workforce? What processes we're going to use? All of those, I think, are things that many are sorting through right now or reassessing.
Another thing to keep in mind when you're looking at how you triage patients coming into a spine program or a back pain program is where that entry point is and where the bottleneck for access is. We've spoken to a program recently that identified that most of their patients were coming in through the emergency department for back pain and spine. I don't think that's unusual. They wanted, for this particular patient population, ensure that they had very quick access to an appointment. They've essentially put that triage and the scheduling being triggered in the emergency department. That has really helped them add capacity, essentially engage independent providers in their market, and help patients who want to see a provider in the next 24 hours, 48 hours. Even if that patient has to drive a little bit further from their home, they give them the option to do so.
Well, and I have to imagine that that helps immensely with patient satisfaction, the ability to quickly connect somebody to a care pathway and get them on that treatment journey.
And it's a key point of differentiation as well. So many programs do offer spine and back pain care that it's become a little bit more commoditized. Part of what you're competing on is access. And if someone's in a lot of pain, they aren't necessarily always thinking, oh, it has to be a surgeon or it has to be this particular type of provider. They want it to be handled, and they want it to be handled yesterday. So access, I think, is a tremendous piece to be working on.
We have another program in the Midwest that has installed physical therapists in their primary care offices. Now, it's not just for spine and back pain, but if you do come into your PCP and you have back pain, they'll offer to let you see that physical therapist right then while you're already in the office for essentially a free consultation. They don't even bill you for the initial consultation. And they also have the ability to just walk into any of their physical therapy sites and have the same experience with a free physical therapy consultation. They have over 75% of patients that do access those two entry points actually end up either receiving physical therapy in their health system or at a specialty visit. Really good capture rate and also highly satisfying for patients.
That's incredible. What a consumer-centric approach to delivering a service within a service line that historically has been rather transactional or procedural in nature. I mean, you're really starting to then think about how you place increased focus on the patient and getting them what they need, meeting their demands versus just capturing that procedural downstream activity.
It's always immediate satisfier in this economy and society that we've developed. It's like, I need what I want right now. I don't think we're going to get away from that anytime soon in healthcare.
And in this economy, love a freebie. Getting a free consult to then get you started on your treatment journey is awesome.
And Tori, it's really interesting you bring that up because it starts to make it sound like more is more. But what we find is that we're getting you to physical therapy first. It can actually have some value-based or cost reduction impacts as well, where we've seen some programs do this. They embedded physical therapy in urgent care, but I would assume that these benefits would extend to any setting where they're going to rehab first. Less imaging was used, fewer emergency department visits. There's a cost management element to it as well that goes along even with that consumerism. So some nice potentials there.
Does it also help delay or reduce the acuity of a downstream procedure? If you get folks started with physical therapy earlier in some of their back pain or degenerative spine conditions, does that then have any implication on downstream procedural demand?
I haven't seen anything that specifically looked at that, but when people are looking at enhanced recovery, typically you're doing rehab before, you're doing rehab after, right? We're getting you like strong beforehand. So I could see the potential for that to be the case, but oftentimes it seems like the lens that we've looked at it through is people end up going to surgery who don't need it. And the way that you tell if that's the case is by having everybody, unless there's red flags or indicators that they really need to go to surgery sooner, at least try rehab first and see if that works. It's sort of the flip, but Tori, I would love to see someone actually take a look at that and see if it helps. I would imagine that it probably would.
Spine has certainly been an area where we've talked about site of care shifts. I'm curious, where do we stand today? Have we seen an acceleration of procedures leaving the inpatient care setting? What's the latest with this piece of the puzzle?
We continually monitor, especially cervical fusion and lumbar fusion. Those are the two procedures where we primarily have seen and will see more shift to ambulatory. We have surpassed the bulk of the outpatient general shift for something like cervical fusion. That's pretty mature in its shift to outpatient, and we anticipated seeing more of a shift to ambulatory surgery for those procedures. Right now in 2024, it's about a 60-40 outpatient to inpatient distribution for cervical fusion. And we're only projecting in 10 years that 6% more will shift to outpatient. It's a really complex procedure. There's a lot of risks involved. A lot of specialty teams are needed to do these. So it's not something that has the high ceiling potential that primary joint replacements have. For lumbar and thoracic fusion, it's a little behind the curve still. It's earlier in its outpatient shift. In 2024, it was about 30% outpatient already, and we're projecting almost 50% by 2034. When we looked at some historical commercial claims analysis recently for these two procedures, we can dig into 3 different sites of care: inpatient, hospital outpatient department, and ambulatory surgery center. The shift to ambulatory surgery center stalled. We thought it would move a little bit, at least incrementally a few percentages every year. But from 2021 to 23, there was no movement in the ASC penetration for these two procedures across the country, at least.
Do we think that that is because of reimbursement rates are substantially lower in the ASC versus HOPD? Is it just based on where the surgeons are based, the sites of care that they work out of? What do you think the driver is for that stagnation?
There are so many market dynamics that come into play here. And we saw this stall for total joint as well. And there was a lot of pent up anticipation of total joint really going to ambulatory surgery centers. One of the primary barriers is legacy ambulatory surgery centers and capacity. When you consider all of the procedures across every different service line that have the ability to go to ambulatory surgery centers, orthopedics and spine are pretty high up on the reimbursement in hospital-based settings still. And they're also more complicated. They have larger equipment. Sometimes they have a lot of trays. We have robotics to consider. And then some health systems across the country still haven't migrated to their ambulatory surgery centers. Ophthalmology, GI, some of those things are just a little bit easier to move. They already have lower reimbursement. They're just less acute procedures anyway. If you're thinking about this giant pool of every procedure that could move, joint replacement's a little more complicated to say, let's get them in there, or these spinal fusions, let's just send them over when you could send something like a cataract surgery instead. Once we have a bolus of new ASCs come online, which we will likely see in the next 24 to 36 months, given some of the relaxation of certificate of need, that capacity will open up. We'll have more ASCs that are designed to take care of spine and orthopedic patients. And that's when we'll see more of that shift happen.
What's new on the payment and policy front?
One of the interesting things that we've analyzed recently is traditional Medicare patient copays for some of these procedures. And we found that for that traditional Medicare patient, it's actually 15% more expensive for them out of pocket to have an ASC cervical fusion than it is to have a hospital-based cervical fusion.
That is not what I would expect you to say. Do we know why that's the case?
There's actually a cap. Medicare caps the copayment on hospital-based services for traditional Medicare patients. That cap doesn't exist and it's not in place for ASC procedures. This is an interesting analysis to do for all of your payers, especially if you find that there's been some patient resistance to ASCs. There are some markets where patients are not going to know that there's a difference. There's definitely patient populations that aren't going to be savvy in looking at the copay difference. But if you have a lot of traditional Medicare patients and you're seeing some resistance to ASC, it might be interesting to look at what your percent of traditional Medicare patients is, and then what your Medicare Advantage plans look like as well.
that patient-specific consideration is the potential for financial toxicity, another component that we should be considering as we're looking at site of care. More broadly, Medicare has implemented a couple things that are pushing us more towards the ASC. So the copay may be higher for the patient, but from a policy perspective, we are seeing a variety of new policies that may be nudging us in that direction. Donnelle, probably not as heavy-handed as some of what we've seen on the commercial side for other musculoskeletal site of care restrictions for less heavy-duty procedures, but we're seeing it happen, and that's probably another one to talk about. Where we've seen it so far is typically it will be policies that target hospital-based procedures, which makes ambulatory sites become more attractive for that same patient who might be a good fit for it, just because there are going to be fewer hoops to jump through. You've probably heard us talk a few times now, just over the last couple of years, about prior authorization requirements through Medicare fee-for-service that are specific to hospital-based outpatient procedures and apply to things in spine like facet joint interventions, cervical fusion with discectomy, spinal neurostimulators are the three, and this just applies to hospital outpatient departments. Now, we are seeing more broadly just across healthcare some efforts to rein in the burden of prior auth, whether it's reducing the turnaround time that payers have to review requests, or even some of the efforts around gold carding. And this has been a thorn in the side for a lot of programs that's caused delays, but also nudged more volume to that ambulatory site as a path of lesser resistance. And now we have the team model coming up for mandatory bundled payment that for now it's inpatient and hospital outpatient based procedures, and spinal fusion is part of that. That's what's happening now for spine. We'll say that there is good reason to believe that eventually these sorts of policies may extend to ambulatory sites as well. But in the short term, if they're targeting the hospital, it's going to nudge more to go to the ASC. And we may be considering patient copays as part of that equation.
The team model CMS projected that it would impact 500,000 discharges over that 5-year period. And they just came out with a list of hospitals. So if you're curious, the list is out. You might not have heard, but you likely already know spinal fusion is included. It's one of 5 of the procedures that are included in this new model. And we took a high level look at the magnitude of the team model across the different procedures using our forecast tool. We looked at all of the Medicare volumes for inpatient, outpatient, both sites of care, because if something is ambulatory, it could also be hospital-based. In 2026, our projection is there'll be 271,000 spinal fusions for traditional Medicare or for Medicare volumes. You have to take out and just look at your Medicare fee-for-service patients if you're doing this analysis for your own market. That percentage could vary. In the US across the country, it's about 46% of Medicare beneficiaries are covered by fee-for-service. And then for spinal fusions and for Medicare volumes, we're projecting by 2030, which is when the team model would end, a 10% increase in volumes. So a quick way to start to get a handle on how many volumes in your market or for your facility might be impacted by this. And it would be interesting to see how that shift to ambulatory is maybe accelerated by a new bundled care program, just the burden of it for health systems and physicians. It's comparing spending. You have to measure your performance on hospital admission, patient safety, patient reported outcomes. They are really targeting those procedures and higher reimbursement sites of care.
Very important inputs to that patient stratification concept as we do think about how do you strategically think through likely utilization across care sites and how do you plan for facility development from there. Not dry at all, very important considerations as it relates to policy and payment. This is such a great update. I get the pleasure of working with you all on a day-to-day basis as it relates to new content that's going to come out from the group. What's on the docket can our members expect to see next from the team?
We actually have a webinar that we did with NERVS, which is a professional organization for neuroscience administrators. The recording is available on their website. So if you're interested in seeing that webinar that we did with a leader from the Mayfield Clinic, be sure to visit their website and get that. And Kate, what do we have in store for 2025?
For the webinar, we're going to have a link to the recording posted on our website as well. And we talked a little bit about ambulatory surgery center shift, and Mayfield has been doing this for a while, and they talked a lot about what it takes to be successful and also a little bit about what it takes to be a good partner if you're a health system maybe looking to partner with a physician group, because Mayfield is a large physician group. Last year, we did a newsletter that was spine focused. So we're going to do more of that in 2025 for those who are looking at spine specific content as a collaboration between between ortho and neuro, which is great. We're already getting started on our 2025 impact of change forecast nationally, which Tori is aware of as well. So we're starting to talk about some of the new trends and things that we're going to be adding for that.
Awesome. Kate, Donnelle, always a pleasure to have you on the podcast. Thanks so much for joining.
Thanks for listening. If you like this episode, please subscribe, rate, and review us, and or follow us on Twitter and LinkedIn at SG2 Healthcare. And if you want to talk more about innovative healthcare strategies, you can always email me at sg2perspectives@sg2.com. Finally, SG2 is a Vizient company, and there are a bunch of Vizient podcasts that you might like. You can find them at Vizient /podcasts. Have a great day.